Hi, can everyone hear me? Okay, welcome. My name is Ray. I'm going to be your moderator today. We're very excited to have almost 300 of you guys join from over 40 states and some from abroad. Welcome to the 2022 National APAMSA Internal Medicine Bootcamp. We have a variety of topics today. We tried our best to select the most high yield topics that we encounter as residents and fellows. The program today will be organized in 3 parts with 5-minute intermissions. While each presenting speaker speaks, the remaining 3 non-presenting residents will answer your questions in the chat box. Also, new this year, if you are an audience member and want to answer a question from your peer, please announce your name, school, and year of training, and feel free to participate in answering questions. I'm going to start by introducing our 4 wonderful speakers. First, we have Dr. Ilagan Ying, who comes from Philadelphia. She did her undergrad training at Yale, went to UCSF and a Yale School of Medicine for a residency. She is part of the clinician educator distinction pathway in the resident procedure team and is going to go into GI. Now, she has a fur baby, Ollie, and enjoys outdoor hikes, baking, interior design, and art. Next, we have Dr. Lee, who comes from Chicago, Illinois. He went to University of Chicago for his BA and his MD PhD in immunology. He is here as part of the Physician Scientist Accelerated track at Yale Internal Medicine program and as part of the Residency Executive Council. He is also involved in wellness activities together with Isa. He enjoys chess, all things sports and physical activity, hiking, sports travel, literature, museums, and crashing go-karts. Now we have Dr. Miles Shen, who comes from Redwood, California. He went to Princeton, followed by med school at Rutgers, and came to Yale for internal medicine residency. He's part of the resident procedure team as well, and is going to go into cardiology. He enjoys photography, video games, interior design, and has fur baby kitties, Mr. Bean and Luna. Dr. Akash Gupta hails from Louisville, Kentucky. Went to a School of Medicine there, followed by a stint in ophthalmology before he decided to come into internal medicine. Here, he is also part of the clinical educator distinction pathway and the residency executive council and plans to go into rheumatology. He enjoys food and is president of the Ollie fan club, Ollie being Yisa's pet. Myself, I come from Toronto, Canada, and I previously served as the national president of the National Board. I love APAMSA. APAMSA was the best part of my med school experience, and I enjoy meeting med students from across the country. So I want to emphasize that all of the residents who are here today are doing this completely on a volunteer basis for free. And we really want to help you guys. We strongly believe that internal medicine is within the grasp of everyone, and we want to help you be a good intern and a good sub-intern. We'll start with GI bleed by Dr. Isa Ilagan Ying. And I will let Isa start screen sharing.
All right, guys. So my name is Isa, and I'm going to be teaching about the approach to GI bleed first. And I just want to give you a warning that there will be poop. You have been warned. Let's get into it. So the first thing you want to do with the GI bleed is to identify where the bleed is. Usually we like to go by anatomical landmarks just to give us a scaffold for differentials. We usually use the ligament of Treitz, which separates the last portion of duodenum from the beginning portion of the jejunum or small bowel. And it allows us to think about an upper GI bleed versus a lower GI bleed. In an upper GI bleed, if the blood is coming out of your mouth, the fancy word for this is hematemesis, emesis of heme, heme or blood. If it's coming from below, it's often dark and tarry. So we call this melena. I will have a small side note that if the upper GI bleed is brisk enough, it will come out bright red because it just travels so fast down the rest of your digestive tract. For upper GI bleeds, you really want to think about GI tract damage as the origin, variceal bleeds or AV malformations, gastritis or gastric cancer, or blood disorders like hemophilia. Oftentimes when you're on the GI service or a liver service, they will ask you to give a broader differential of GI tract damage. And so we have to think really from top to bottom. If you're going in your esophagus, you're worried about erosive esophagitis, or GERD, so reflux, can cause bleeding with really bad ulcerations. You also want to think about Mallory-Weiss tears, Boerhaave syndrome, people who retch really hard and can cause perforations of your esophagus. You then want to think about in your stomach, ulcers. And so you want to get a good history about what medications might predispose you to ulcers, such as steroids, aspirin, or NSAID use. And then the last one is to not miss is peptic ulcer disease, which is often associated with H. pylori and require extra testing. For lower GI bleeds, it's often maroon colored or has little flecks of blood mixed into it. And so we call that hematochezia. The differential for lower GI bleed is a little bit more simple. So diverticulosis, if there's inflammation involved in one of these pockets, that's diverticulitis. Colorectal cancer, so make sure all your patients are up to date on screening. And notably, the age of screening has now dropped from 50 to 45 in average risk adults. Intestinal ischemia is another cause, which is pain out of proportion exam when you don't have perfusion of your abdominal organs. And then hemorrhoids are a don't miss for an intern who has to do a rectal exam at least once during intern year. Miles can tell you more about that. For patterns on testing, cheap and simple ways to test for GI bleed is the BUN to creatinine ratio. The number to remember is if it's greater than 36. This is likely going to be a upper GI bleed. The reason why is when you have a high BUN, this corresponds with a high red blood cell destruction. Sadness. If there's a slow bleed persisting up to a week and you're only losing 50 to 60 cc's of blood at a time, this is more likely consistent with melena, which is that slow upper GI bleed. You can pick this up on an FOBT test or a FIT test, which is you might not notice it by looking at the stool itself, but you can pick it up with the more sensitive testing. You can also just listen to the bowel and find hyperactive bowel sounds. And then if a patient is in the ICU setting with a nasogastric tube already in place, you can aspirate and see if there's blood in the stomach or blood in the duodenum, depending how far down your intubation is placed. Here's your warning. This is the classic example of melena versus hematochezia. Notice on the left, it's almost black. So whenever I interview a patient in the morning pre-round, I ask them, or I point to the television remote and I say, is it this black? Is it this dark? Because if it's not that dark, then often it's not really true melena. Also note that being on iron supplementations and Pepto-Bismol can also make your stool look really dark. So that has to be on your differential. Hematochezia is, again, a rite of passage for every intern. If you look into the toilet because the patient decided not to flush just for you, this is what it usually looks like when you're pre-rounding. And so to treat the bleed, the 3 steps are to stabilize, to scope, and to stop the bleed. Stabilizing means resuscitating them for the volume lost. You want to have 2 large bore IVs. And I just want to remind you guys that large bores goes by gauge, and that the lower the number, the larger the bore. And so typically we want 16, 18 gauge needles, which are larger than say the 20 to 22 gauge. Some institutions will allow you to use a 20 on the fence, but 16, 18 is what you'll need to know in your standardized settings. You then want to resuscitate through these 2 IVs, primarily with normal saline first. It's cheap, easy to get, and volume expands fast. At the same time, you're sending off a Titan screen. And if the patient's really unstable and actively bleeding, you're going to order a massive transfusion protocol or get the box of blood products yourself and order transfusions for hemoglobin goal, typically greater than 7, greater than 8 for patients with acute coronary syndrome. And if they're in the ICU and they're still bleeding, you're ordering pressors with your resident. If you think that there's any gut translocation risk because of ulcerations or a disruption in the normal mucosa, you're going to order antibiotics. If you think that there's a concern for variceal bleed, you want to stop the variceal bleeding with octreotide, which is a synthetic somatostatin. And then if there's any erosions or active inflammation, you want to coat and stabilize the acidity of the stomach with a proton pump inhibitor. In our institution, we usually use pantoprazole. For scoping, there's 3 ways to scope, and this is usually the fellow. They do an upper GI bleed, they do an EGD. For a lower GI bleed, they'll look with a colonoscopy. And then if they are really convinced that it's just the lower portion of the GI tract, like a hemorrhoid or a rectal varices, then they'll do a flex sig. In order to stop the bleed, again, the fellow will likely do ligation banding of the variceal bleed, epinephrine injection of bleeding blood vessels, thermocoagulation, or clipping. And if they've done all these things and the patient is still bleeding, their hemoglobin is still dropping, you're probably going to want to order a CT abdomen and pelvis with contrast, because you want to look for extravasation of blood to look for bleeding that you missed elsewhere. And they might need to even consult IR, who can then do an embolization of a bleeding vessel from behind if a GI doctor can't get it from ahead. Pause for a second there, and we'll go to our next topic. I combined the next 2 topics together because they all follow under the umbrella of the management of decompensated cirrhosis. This is a real talk I give on the wards for students on the liver service. And as an aspiring hepatologist, I wanted to share this talk with everybody. The first thing to know is that the phrase decompensated helps differentiate how sick your patient is with cirrhosis. They're either compensated or decompensated. Decompensated cirrhosis usually has 4 criteria, which we'll talk about the management and treatment for each. But also you want to know the MELD score, which incorporates sodium, and the child Q score of the patient with decompensated cirrhosis. This allows the team to know how sick your patient is, how high up they are in the transplant list, so a higher number is a sicker patient. And the reason why we do this is because it gives us an idea of just how many times they've been in the hospital, can we get them to liver transplant, and can we get them cured of this disease? And as a side note, you want to also know why they have decompensated cirrhosis. And so we write often secondary to, which is that 2/2 sign in notes. And the most common reasons for decompensated cirrhosis are hepatitis C and hepatitis B, alcohol, which is also written as ETOH. And then if it's non-alcoholic, you can hear fatty liver disease, metabolic associated fatty liver disease, non-alcoholic fatty liver disease, all the AFFLDs, MAFFLDs, and NAFFLDs. Alrighty. So what do you have when you are decompensated? 4 things. H stands for hepatocellular carcinoma, or HCC. A stands for ascites, or fluid, often in the belly. V stands for variceal bleeding, and E stands for encephalopathy. So I'll cover these 4 topics all in one go. For hepatocellular carcinoma, or HCC, this is progressive cancer due to fibrosis, which worsens with inflammation in an angry or damaged liver that then starts to develop malignancy. In order to screen for this, you want to order ultrasound every 6 months, Q6 months. And some society guidelines also add on AFP, which is a blood level marker that can be associated with HCC. The question you're going to be asked by every attending at some point with liver disease is, what kind of imaging do you order to look for HCC? And so here's your answer. It's either a quadruple phase CT or an MRI hepatoma protocol. The one that they really want you to explain is a quadruple phase CT because it tells you a lot about the cancer itself. In the first phase of a CT scan, you do non-con, so the liver is just homogeneous. Then you inject contrast. And in the late arterial phase, you have hyper enhancement of the HCC nodule. And the reason for this is that cancer loves hepatic artery or arterial blood, has lots of oxygen or whatever oxygen is left. And so the hepatic artery, so it'll take up most of that contrast first. And then rather compared to the liver parenchyma, which only takes about 75% of its vasculature from the portal vein. In the portal venous phase, it then washes out. And then in the delayed contrast, you can see that there's like a lingering left of the lesion. And so that hyper enhancement on arterial phase with delayed washout are the buzzwords that you're looking for when you're looking for HCC on a CT quadruple phase. Next for ascites is for management, you want to think about salt restriction and diuretics. The 2 diuretics that we tend to use in liver land is spironolactone and furosemide. I'll try to use the generic terms, but in our institution, we like to use brand names a lot. Furosemide in patients with liver disease starts usually at 20 milligrams to up to 160 milligrams daily. And then in spironolactone, it's 50 to 400 mg BID or daily. QD means daily, so I just want to get you guys used to seeing how this is written out. We do this in a low balance, unlike patients with heart failure, because liver patients have a very difficult way, are very fluid sensitive. And so diuresing a liver patient compared to a heart failure patient, it's a different anatomy and they're very sensitive to fluid shifts. So we start slower and we go slower as we titrate up. We also do it in this combination because it balances that potassium level, where furosemide is potassium, you lose your potassium, and then spironolactone is a little more potassium sparing. If the patient cannot be managed with their ascites with salt restriction and diuretics alone, you then have to physically put a needle into their abdomen, which is called a paracentesis. And you might have to do this multiple times, inpatient or outpatient, and this is called serial paracentesis. So just to let you know, if it's larger than 5 liters taken off, this is technically a large volume paracentesis. And often institutions will ask that you also give albumin for every liter that you take off above this level to prevent these large fluid shifts. The latest society guidelines have shown that anything greater than 9 liters has a bad risk or higher risk of paracentesis-induced circulatory dysfunction. And so we technically don't want to remove more than 9 liters if we can. And this is different from 2 years ago where we were taking 10, 15 liters off of an abdomen in one go. And then if a patient truly continues to have ascites despite serial paracentesis, then you might want to refer them to IR for a TIPS procedure or a transjugular hepatic portosystemic shunt. And what they do here is they create a shunting bridge to completely bypass the liver so that you no longer have this congestion and fluid buildup from the liver trying to filter, with a risk of increasing their hepatic encephalopathy or increased uremia in their venous system. The next topic is variceal bleeding. There's small varices and there's large. If you can insufflate and press this down, then this becomes a small varices, pressing down meaning with air in an EGD. If it's large and it's very bulging and you're really worried that it's going to pop, that's scary and you have to treat it. And we already talked about the ways to treat it with banding. And then additionally, you want to give this patient a non-selective beta blocker. Non-selective beta blockers being carvedilol, nadolol, and propranolol. Again, just like our GI bleed topic, you're going to stabilize, scope, and stop the bleed. But at this point, you're also going to prevent rebleeding. And so to prevent the rebleeding is that non-selective beta blocker with nadolol, propranolol, and carvedilol. You don't give all of these options. You choose one based on the dosing and the preference of the patient. And you want to titrate to a heart rate goal less than 65, because studies have shown that if you can get their heart rate less than 65, that these large varices are less likely to pop, is what we call it. The last one is encephalopathy. So increased confusion due to circulating uremia in the blood because the liver is no longer filtering as well as it should. Primarily, you want to tell the patient to focus on getting their protein from veggies, and then white protein is what we tell them, but veggie protein is better. Then you want to think about precipitating factors for encephalopathy, and every liver attending will ask you, what are the predisposing factors for encephalopathy? Because this is often a reason why patients are admitted, and so you have to do this workup. And so the common culprits of encephalopathy in the patient with decompensated cirrhosis is infection, bleeding, sedatives, because their liver cannot process sedative meds as well, pre-renal azotemia, a splenorenal shunt, which is pretty uncommon, but enough to warrant that patients get additional abdominal imaging to make sure that this isn't happening if every other workup has been negative. And the last but most important is bowel regimen. And so every patient with decompensated cirrhosis and history of encephalopathy, you want to make sure that they're making adequate bowel movements. Your goal is to do at least 3 bowel movements per day. And if the patient continues to have encephalopathy despite pooping 3 times a day, you're going to just keep moving this up to 5 bowel movements per day. And as you can imagine, that's pretty regular. And so the medicines that we like to use, which Dr. Gupta will talk about more for his constipation quick coverage, but the ones for liver patients are lactulose and Miralax. Lactulose is a clear syrup that tastes really sweet like boba. Miralax is a flavorless powder that you mix into water. You can take these up to 3 times a day, depending on how many bowel movements that patient needs to have. And then your last resort is if a patient is lactulose intolerant or has more than 2 hospitalizations for hepatic encephalopathy, despite all this adequate workup, despite making their bowel movements, then you're going to put them on prophylactic rifaximin. And that's a low dose, mixed gut flora, poorly absorbed antibiotic that just prevents further, let's say, like SIBO from happening. All right, and on to my last topic. The dreaded complication of ascites is that if the fluid in your abdomen sits there for a while, you have predisposed risk of developing intra-abdominal infections, or that fluid sitting around will get infected. And so this phenomenon is called spontaneous bacterial peritonitis. Typically, you would think that it's from the gut flora because your intestines and your stomach are just bathing in that fluid in your stomach or in your abdomen, but truly it's spontaneous and we don't know because there's no evidence of it. The questions you have to ask is when to tap this patient, when to remove the fluid. And so the 3 criteria is either signs or symptoms of infection. So you want to think about abdominal pain, fever, and chills. Worsening renal function or encephalopathy. So again, knowing that infection is a risk factor for developing worsening encephalopathy. And then clinically significant ascites. So this is a person whom, if you put your hands on their abdomen with consent and do a fluid wave test or percuss, you can appreciate the ascites. This does not mean that a radiologist noted moderate or mild ascites on exam. If this person's stomach looks pretty flat to you and you wouldn't have known otherwise, then this is not clinically significant ascites, and the risk of this developing into SBP is very low. To make the diagnosis, you need to sample the fluid. So the first and most important test you have to diagnose with is the cell count. You're going to physically look in your lab values for the number of PMNs or polymorphonucleoside PMNs, and then which is called granulocytes in our constitution, granulocytes. And the number to remember is greater than 250. So if there's greater than 250 cells per microliter, this patient now has spontaneous bacterial peritonitis. If you have extra fluid to send off, you can do the additional studies, which is culture. This hopefully gives you the bacteria for sensitivities. And then the last one is specialty studies or everything else if you have extra fluid to give. So this is things like lipase, triglycerides, if you want to rule out chylous ascites, protein, and amylase. The most important one here is usually the protein and albumin, because you can then calculate a SAG score, the serum albumin ascites gradient. If it's greater than 1.1, then it's most likely a liver problem or a heart problem. If it's less than 1.1, then you have to look for other reasons of having backup fluid in your abdominal cavity, like malignancy, malnutrition, nephropathy, or even tuberculosis. For the management of SBP, you want to avoid a large volume para if there isn't concern for active infection. So you're not getting, even if they have a lot of fluid in their stomach, you're going to say, I'm sorry, we just need to send off a small amount first, make sure there's no infection, and then we can take off the rest of the fluid later. You also want to get their history and know if it's likely community acquired or if they're a higher risk SBP patient. Community acquired means no history of antibiotic use, prophylaxis in the last 90 days. And there's no history of multi-drug resistance in the past. These patients can then be treated with cephalosporins. In our institution, we do 1 gram of ceftriaxone every 24 hours. If the patient is high risk, they've had multiple episodes of SBP in the past, they have multiple drug resistant infections in the past, then you're going to go broad with them, start broad. Typically in our institution, we do Zosyn. Sorry, Brandon can give like the full name. And then you're going to add on either vancomycin if you think they have a history of MRSA, or daptomycin if they have a history of VRE. And then broader than that would be meropenem and an ID consult. Just because you checked and you saw that there was infection SBP, you have to keep checking. And so you're going to repeat a tap at 48 hours. And you want to make sure that there's a decrease in your PMNs or granulocytes by 25%. This tells you that you're treating the infection correctly. If it's not, you need to broaden your antibiotics or look for other ways or reasons for infection. If you can narrow your antibiotics and you're doing this successfully, we typically try to treat for 7 days of a PO antibiotic. Our choice is ciprofloxacin in our institution, 500 milligrams BID. Another consideration, if this number is not getting better, is to also do abdominal imaging. So if they're having abdominal distension, pain, fever symptoms, rule out free air in the abdomen and get broader antibiotic coverage. And last but not least, if the patient has developed SBP multiple times, you might need to just consider prophylaxis antibiotics. And so you're going to give them usually an oral ciprofloxacin, 500 milligrams daily is usually what we do, or a Bactrim double-stranded tab about every day. Awesome. Those are all my topics. You are now all junior liver experts. This is my email if you guys have any questions. And I have to give credit to the godmother of all cirrhosis and variceal bleed care, Dr. Garcia Sao, for inspiring these talks. I'll give the screen over to Dr. Brandon Lee, who can better explain the approach to febrile illness and infection than me.
Okay, hi everyone, I'm Brandon. I will talk a little bit about febrile illness, and specifically I'm going to talk about inpatient approach to suspected infection. As you guys probably know, there's a ton of reasons to have fevers, but we're going to concentrate on one that you'll hear about often in the hospital. So the first thing you want to ask when you're wondering about a fever, your nurse calls you and says, hey, there's a patient who has a fever. You want to know who is the patient you're dealing with. What are they young? Are they immunocompetent? Do they have few comorbidities, COPD, diabetes, asthma, uncontrolled hypertension, etc.? Or are they elderly, immunocompromised, and have tons of these comorbidities? This helps you build a framework on, is this patient someone who's going to crash really quickly if I don't fix a problem, or are they going to have some durability to them? The next thing you want to ask is the infection systemic or local? Are they toxic appearing? And what I mean by that is, really the best tool you have are your eyes. How do they look? Are they really diaphoretic? Are they having rigor, so violent shaking? Are they suddenly confused? Do they have any evidence of shock? So this is blood pressure that's low, systolic less than 90, a MAP less than 65 for your ICU people. And this is in despite of fluid resuscitation, 2 liters over 2 hours. Do they have other high clinical scores of severe disease? And I'm going to pull up 2 scores, which you may be familiar with and as med students, a Q-SOFA score. So if you have 2 or more of these criteria, GCS less than 15, this is a glaucoma or Glasgow coma score, respiratory rate that's high or low blood pressure, or if you meet the SIRS criteria. So if you have a fever, hypothermic, have a high heart rate, respiratory rate, or a high or low white count. And taking this first question or set of questions together, you want to ask the second, which is, do you have time to figure out what's going on? And if the patient is really sick appearing, they're in shock, then you probably don't. And I'll tell you what you can do in those moments. But what if it's really unclear? You have someone who's kind of sick, who's still kind of talking to you, has a high fever, but they look okay from what I just told you. Well, you have some other clues, and there's other signs of end organ damage that you should look out for. Do they have an elevated lactate? Are they hypoxic? Do they have any evidence of AKI? Do they have any evidence of DIC, liver failure, changes on ECG or trope? And notice that I'm pointing these things out because they all address different organs. You're trying to look to see if there's any evidence of end organ damage or otherwise known as hypoperfusion to the organs. Taking that all together, If you don't think you have time, so if someone's really in shock, if they have multi-organ failure, if they really look sick in the setting of a fever, then you want to review the high yield stuff. What's the most important? Did this person just get a procedure or not? You want to monitor their vitals frequently, monitor them closely, make your workup broad. You can be cute by trying to say, hi, I see a little cellulitis on the butt or something like that, but you may not be right about it. So you want to make sure that you're broad. Don't miss anything. Don't tunnel yourself really narrowly to start. Examine your patient, look everywhere. Get a broad workup. CBC, CMP, lactate, procal are very helpful in these cases. Do you need to get cultures? Oftentimes you will. Blood cultures are often collected on respiratory urine stool, depending on the history of the patient. Do they need an LP? Do they have meningitis? Do you need any imaging? If it's really not clear to you, do you need to see if there's a source? Do they have a recent abdominal procedure, and do they need a CT of the abdomen stat? And this is definitely not least, but is listed last. Do you need help? You guys are all going to be going to a residency program. You're going to be being in a training environment. Use the resources available to you. Do not hesitate to call for a consult, ask the MICU or step down attending fellow. Doesn't matter how high in the hierarchy there are, just ask for help. The sooner you ask for help, the better you'll be as a resident and a doctor to the patient. Once you're doing your workup, make sure you treat now and you treat broad. Cover your troublemakers, which I'll talk about in my next presentation. Gram-positive troublemaker being MRSA, gram-negative being Pseudomonas. And you may consider atypical organism coverage, which I'll talk a little bit more about later. And if it's not the sort of do or die moment, if you do have some time, take some time to review the history of your patient. It may be more subtle to find the source of their fever. You don't have to get Q1 or 2 hour vitals if you think they're stable and doing okay. You can still keep your Q4 or every 8 hour vitals, depending if it's appropriate to the patient's physical appearance and status. You can start to form your differential. What is the constellation of symptoms? Is this patient having a fever in a setting of diarrhea or urinary symptoms? Find the source, use the history to help you. Get labs as appropriate, cultures and imaging as appropriate. These are not must-haves. And consider if you need help. You may need to ask the ID fellow to help you narrow down a little bit more. And then you have a larger window to treat. You don't need to necessarily start antibiotics right away. You can start it in 1 to 3 hours, depending on what you think the source is after doing a thorough investigation. You can ask yourself, do you need MRSA coverage and Pseudomonas coverage? Is your patient immunocompromised? Patients who are immunocompetent, oftentimes you can start a narrow approach. If you have someone who has, say, cellulitis, you can start, cefazolin or penicillin, a simple medication. You don't have to cover all the other organisms. But if you have someone who's immunocompetent and say neutropenic, you have to start broad, even if they look otherwise well. So there are special conditions, but hopefully this is a good sort of general framework based on how much time you have. So the general summary that I want you to take away is when you're treating someone with a fever and really any syndrome, know who you're treating to start with. Are they frail, immunocompromised, or elderly? Figure out if you have time. Is there a systemic problem or is it localized? And if you don't have time, get a broad workup and treat broadly. Ask for help. And if you do have time, figure out where your fever could be coming from, start narrow, and still ask for help if you need it. And that brings me to my next presentation, which will address antibiotics. So I threw out some names out there. I'm sure it sounds like alphabet soup, and hopefully this antibiotic lecture will help simplify that. I'm taking this from Yale 20's lecture series, which is very much something you guys should look into. It's very helpful. And they use something called the antibiotic triangle of truth. And the way they organize this is into anaerobes, atypical spirochetes. So the weird ones you guys have heard of, they lump it all together. And then they have gram positives and you have gram negatives. The first I'll talk about is gram positives. And pay attention to the coloring highlights because it'll make sense in a moment why I color these things. So first with gram positives, you have troublemakers. And the troublemakers you want to be careful of are MRSA, otherwise known as methicillin-resistant Staph aureus, just an antibiotic-resistant version. And it causes a lot of problems. The way you can treat this if you're worried about that being a source or the cause of your infection is vancomycin. IV only, you can't do PO. The second thing you can consider is clindamycin.
Did you switch your PowerPoint? I think we're still on the last slide of your previous presentation.
Oh, my goodness. Okay, sorry. Thank you so much. That's really helpful. Let me do this. Share next one. All right. Can
We're
you
just
see the right
making
one?
sure everyone's paying attention, guys.
Can you guys see this one now?
Yes.
Okay, perfect. And I'm going to go backwards. All right, cool. Antibiotics, triangle of truth. Anaerobes, atypical spirochetes. You've got your gram positives, your gram negatives. The main troublemakers are MRSA. As mentioned, you will use vancomycin often. You can only give it IV. It does not absorb bloodstream if you give PO. You can consider things like clindamycin, Bactrim, or otherwise known as, I can't pronounce it. It's TMP-SMX. Sulfamethoxazole trimethoprim. Doxycycline is also another one that you can consider. I'm going to put on some other names that you may hear, and this is really just so that you kind of recognize what they kind of are: ceftaroline, daptomycin, and these vancins. In terms of the gram negatives, the troublemakers that you want to be worried about are Pseudomonas and ESBL, otherwise known as extended spectrum beta-lactamase harboring bacteria. Really, Pseudomonas is the one I think about most. And the antibiotics you want to have in your back pocket are things like ceftazidime, cefepime. You want to think about Zosyn, otherwise known as piperacillin tazobactam. I also put another thing, ticaracillin clavulanate. This is mostly used in Europe, but it's kind of fading out now. And then you have your penims like meropenem. There are other things like aztreonam that you can use. And this is if you have allergies to penicillins, cephalosporins. And that's sort of the last thing, aminoglycosides, which are very, very toxic, but we often use it in Pseudomonas coverage if they're really worried about Pseudomonas being a problem and the patient's doing really poorly. So I've talked a lot about what happens with troublemakers. Well, what about the ones that aren't as trouble? You still have to treat those. And typically we think about penicillins. They cover gram positives like MSSA and strep. That's why it's highlighted in red. But a thing that I'll cover in my next slide is that not all antibiotics just cover one group of organisms. There's a lot of overlap. So some of your penicillins will have gram negative coverage highlighted in purple. And some famous names you'll hear about are things like Unison or Augmentin. Cephalosporins are often used to cover gram negatives that are not necessarily the troublemakers or resistant, things like E. coli, but they do have some gram positive coverage highlighted in red. You'll have, depending on the generation, which is listed here, some cephalosporins will have better gram positive coverage than gram negative. And it becomes more gram negative coverage type as you become a higher generation of cephalosporin. Okay, so that's enough about gram positive and gram negatives. What about the weird ones? So you have anaerobes, and you may hear anaerobes in the setting of GI infections. You may hear them in the setting of aspiration pneumonia. And when you have anaerobes, you want to think about if it's above or below the diaphragm. If you have an aspiration pneumonia patient, depending on the case, you may consider things like clindamycin for above the diaphragm. If you have, or an abscess, for example, an oral or head and neck abscess. If you have below the diaphragm problems, a GI infection, you're asking ISA to come help you, you will then think about things like metronidazole. Of course, things like Unison, Zosyn, meropenem are also used to cover them as well. Now, what about the really weird ones? These are the ones that you always forget about for your tests. Things like atypical spirochetes. Often you'll think about like Lyme's disease as a thing that comes to mind. Your cyclins will be very helpful and your macrolides. So tetracyclines, doxycycline may sometimes be appropriate. Macrolides like azithromycin, you'll often see this more in like community-acquired pneumonia when you're covering atypicals. The last thing I want to talk about is fluoroquinolones. Why did I not put them in one category? Well, it's because they actually tackle everything. Fluoroquinolones are really helpful. They can cover a lot of different organisms. I've highlighted in purple for you the one ciprofloxacin, which is really good for gram negatives. And the red ones are really your respiratory fluoroquinolones. They also have a lot of coverage for gram positive organisms. So they can cover your staph, and actually some of them can cover your MRSAs like delafloxacin. So I want you guys to take the time to save this screen. The way I've designed my lectures is to help you have a resource. Obviously, we're running through everything really quickly. I want you to have this so you can reference it when you're an intern or a resident, okay? The next thing is just a, quote, simplified antibiogram. I don't expect you guys to know everything about antibiotics after this lecture, but hopefully this biogram, which I took from another source, will help you see names when you're a resident and know generally what they cover. That's the purpose of these biograms. You'll see names like ciprofloxacin, gentamicin, and you may wonder what are they covering. Hopefully this can help you use that. And I want you to take a picture of this or look for resources like this to help you when you're a doctor on the wards. Okay. Now, the last thing I'm going to cover, I'm going to stop share because I don't know how to do it any other way. The last thing I'm going to cover is really not related to antibiotics at all. Oops, sorry. Hold on. It's related to diabetes because of course that fits afterwards. So the next thing I'm going to talk about is inpatient diabetes. This is another common thing you'll cover on the floors, and you will often be told some patients hypoglycemic, hyperglycemic. And I'm going to try to help you figure out how you start insulin and how you titrate it when you're on the wards. The take-home point, as mentioned here, the biggest take-home point, sliding scales are terrible. Please don't use them as your only way of doing things. And I'll hopefully show you another strategy to address this. When you have a diabetic patient, the first thing you want to look at is what kind of diabetes do you have, okay? And is it poorly controlled? Of course, type 1 diabetes are patients who need insulin all the dang time. For patients who are type 2, they may or may not need insulin. It depends on how much native insulin they're producing and how much sensitivity they have to insulin. On admission of your patient, when you get one, the thing I want you to take home is that oftentimes they will be on oral hypoglycemics, like metformin, for example, and you'll want to hold those and place them on insulin. And I'll show you how to do that in a moment. If a patient's already on home insulin, you may or may not need to adjust this, but it's not always stop it or start it. It'll depend on why they're in the hospital. When you have someone on insulin, the goals you want to keep in mind are avoiding the extremes, hypoglycemia and hyperglycemia. They all have their own issues. Obviously, hypoglycemia, a patient can pass out. They can be really confused. They can be altered. Hyperglycemia, it's not always the most obvious, but it can cause huge problems like poor wound healing, much higher risk of infections, longer hospital stays, and oftentimes the procedures will be delayed. So this is not something to mess around with either. Generally speaking, the goals you want to keep for insulin goals are in terms of blood sugar. You want to keep, if you look for blood sugars and you see that they're above 140s and persistent, meaning after 2 measures that are a few hours apart, it'll depend on the setting of the patient. If they're an ICU patient, you want to keep their blood sugars a little bit high, but not too high, 140 to 180s. And if they're not an ICU patient, then really you want to keep them less than 140, but not too much, right? You're not going for home goals where you're okay with blood sugars in 90s, 100s. You want to keep them sort of like somewhere comfortable where you're not going to have a hypoglycemia problem. Okay, so how do we do that? Well, what's at our disposal? So the insulins that we have are these 4 generally. Lispro, you may have heard, is a very short-acting insulin. It's used in pre-meal and sliding scales. Regular insulin is often not used unless you have someone who's NPO or someone who is on tube feedings. We won't get into tube feeding mechanics in this lecture, but I just want you to be aware that there's 2 different types and they're not the same, regular and Lispro. And NPH, usually this is helpful if you're anticipating high blood glucose increases, such as when you're giving steroids, prednisone for a COPD patient or COVID, unfortunately now, right? And we won't talk too much about the specifics of that. Glargine and Lantus are very common ones. This is your basal long-acting in 24 hours. And you'll see that you'll be able to combine your long-acting with your short-acting. Okay, now how much insulin do I order? I know what tools I have a sense of what kind of patient I have. What do I do next? Well, if you have a patient who has had insulin in the past, you can adjust it based on how critically ill they are. If they're ICU type of ill, as mentioned, your blood glucose goal is a little bit more tolerant, 140 to 180, but you'll often have a hard time managing them. I wouldn't be surprised if they're on an insulin drip. Often these patients will be started on some reduced dose of their home insulin amount, depending on how sick they are. If they're not critically ill and you have this blood glucose goal of less than 140, you can take their home insulin and drop it to 25, 50% of the normal amount. And that's usually because in the hospital, we put these patients on diabetic diets, not eating as much. They don't like the food. Trust me, no patient will like your hospital food. So because they're not eating as much, you will probably need to reduce the insulin amount. If they're insulin naive, you'll have the same goals as above, but you'll have to determine a total daily dose of insulin and also add sliding scale for pre-meal correction. Now, how do we do that? So to determine the total daily dose of insulin, you need to basically take into account their body weight as well as their patient characteristics. If you have someone who is underweight, who's older age, who's on hemodialysis or has bad kidney disease, you want to take the total daily amount of insulin is calculated by taking 0.3 units and multiplying it by their total real body weight, not ideal. If it's a normal weight patient who happens to be diabetic, you've got an A1C and you're surprised, then you'll use 0.4 units times their total body weight. If it's an overweight patient, 0.5, and obese, insulin resistant, or on glucocorticoids, you'll take 0.6 or sometimes even 0.7. And oftentimes you may ask endocrinology to help you with this one. In terms of doing sliding scales, which I'll talk about how you put this all together last, your sliding scale will also be based on these patient characteristics as well. If you have an underweight, older patient, hemodialysis, you'll do a low dose sliding scale. If you have a normal weight patient, that's mid dose, and high weight, obese, insulin resistant, you'll do high dose. Okay, so how do I do this? Let's take an example. So let's say you have a 47-year-old guy, very heavy, has a high A1C, so probably very poorly controlled. He's not critically ill. How would you approach this insulin management? So first, I would guess that this is certainly an obese individual. He's insulin resistant probably. So I'm gonna take the 0.6 units as mentioned. I'm gonna multiply it by their total body weight, and that's how much insulin they'll have per day. And the reason why I took this example is because I don't want you to be frightened by high numbers. These are conservative estimates, okay? You cannot make someone hypoglycemic usually if you use these kind of calculations. The way you then figure out their daily basal bolus is you then you divide it by 2. So you'll split half of the total daily amount into how much you'll give as Lantus, a long acting, and how much you'll give as pre-meal. That's your bolus, okay? Of course, there's 3 meals a day, usually, and you'll split the insulins based on that, okay? So it's 27 units pre-meal. Then the last thing you'll adjust is sliding scale. So in this case, I've decided this patient is high BMI, their poorly controlled diabetes will be a high dose sliding scale. And keeping in mind that the sliding scale doesn't necessarily correct a higher blood sugar, it's what you do to basically compensate for what you calculated as your bolus and your blood sugar is still high. It'll basically tell you how much you need to adjust later, which I'll address in a moment. Finally, you have a daily regimen of 81 units basal, as say Lantus, 27 units pre-meal for each meal, and you have high dose sliding scale. The last thing you'll do is you'll check daily if your sliding scale, how much do you need of it, right? So the sliding scale will give you a sense of how much you're off by in terms of your pre-meal or your basal insulin. If there's a consistent need for your sliding scale, you may need to incorporate this into your total daily dose. An example would be if you keep getting 12 units of insulin pre-meal correction each time, and you see in your chart that you keep needing this, then that's 36 units of additional insulin. You'll try to factor that back into your total daily insulin needs. So 162 units is the original calculation. You add 36, you get 198. And then you'll split this up as normal. So you'll split it up into basal and bolus, and you'll figure out your total daily need, a new daily need. Another thing I didn't write here is that, how do you adjust your insulin? So oftentimes, if your pre-meal blood sugars are too high, you need to adjust the prior meal's insulin bolus amount. If your AM blood sugar is too high, you need to adjust your long acting. But I decided to leave those nuances out for another time. So hopefully you guys found this helpful. Look at this example slide. It'll be really helpful for you to work through this. There's a lot of math, but you'll be called for this a lot, I guarantee you.
All right, thanks very much.
Thanks, Akash, Miles, and Brandon for answering the questions during my session.
Miles, you want to go ahead?
All righty, should I get started then? Can everyone hear me okay? All righty, great. So hi everyone, welcome back. My name is Miles, and I'll be starting off with a brief intro to Bedside Echo. So Bedside Echo is a quick and non-invasive way of assessing a variety of physiology and pathology states, such as cardiac function, intravascular volume status, valvular abnormalities, pericardial fusion or tamponade, pleural fusions, pulmonary edema, and many others. And my primary goal is to introduce everyone to some important cardiac windows, how to obtain them, and to help familiarize you guys with the various structures you'll see. So there are a variety of ultrasound probes that exist, but these are the most common ones. For Bedside Echo, you'll want to use the phased array probe, which is a smaller probe on the right with an almost square-shaped transducer. It utilizes a lower range of ultrasound frequencies, which means it will penetrate through more tissue and give you greater depth. Also, the small transducer size allows you to get in between the ribs and to better visualize the structures within the thorax. So let's begin. So just for reference, the green arrow on the diagram indicates the direction of your probe marker, which will be present on one end of your ultrasound probe. And this corresponds with the P marker on the top of the screen, and it helps you to orient yourself. So for the parasternal long axis view, as the name implies, you place your probe at the left parasternal region, usually between the 3rd to 5th intercostal space, and you point your probe marker towards the patient's right shoulder. And you'll realize that the names of the different cardiac views correspond to the locations and orientations of your probe, which makes it so much easier to remember. So we've essentially obtained a cut of the heart that is somewhat in line with its long axis. So going through the structures, we see the right ventricle, which is the most anterior structure to the chest wall, and we see the left atrium, which is the most posterior structure. We also see the mitral valve, then the left ventricle, which then forms the left ventricular outflow tract, and then we also see the aortic valve and the aorta. So overall, a nice healthy heart with good squeeze throughout and relatively normal chamber sizes and valves that appear to be opening and closing properly. Next, you can obtain the parasternal short axis view, and you keep your probe in the same position as the parasternal long axis, and you simply turn your probe 90 degrees towards the patient's left shoulder now. So you've now obtained a cross-sectional cut of the heart at the level of the aortic valve. And here you can see the aortic valve in the center with its 3 leaflets. You'll again see the left atrium posteriorly and the right atrium next to it with the interatrial septum coming into view, separating the 2 chambers. The tricuspid valve is barely visible on the very left of the screen, and nearest to the ultrasound probe again is the right ventricle or the right ventricular outflow tract, leading into the pulmonic valve and the pulmonary artery. The next view is the parasternal short axis view at the level of the mitral valve. So to obtain this view, it's very simple. You keep your same probe position and you simply tilt your probe head slightly towards the apex of the heart, which means you're still getting a cross-sectional cut, but you're making your way down closer to the apex. Here you can see the circular left ventricle with the crescent-shaped RV, and you can also see the mitral valve, which you can identify easily because it looks like a fish mouth. And if you keep tilting down, you'll see the papillary muscles in the left ventricle, and lastly, you can visualize the apex of the heart. The next view is the subcostal 4-chamber view, which is a quick and easy way to evaluate cardiac squeeze and also for any pericardial effusions or tamponade. You'll place the probe horizontally under the xiphoid process with the probe marker facing the patient's left. And you may need to apply some pressure with the probe to obtain this view. So you should be able to visualize the left ventricle, the left atrium, the right ventricle, and the right atrium. And that brighter homogeneous structure up top is the liver. The subcostal IVC view is a very important view that we use all the time to assess intravascular volume status. So keeping your probe in the same subxiphoid position, simply turn your probe marker up towards the patient's head. And here you can see the liver and the IVC running underneath it, feeding into the right atrium. Here are some important numbers to remember. If IVC diameter is measured greater than 2.1 centimeters and less than 50% collapsible with a sniff, you literally ask the patient to sniff in. This suggests you are volume up. And if you're less than 2.1 centimeters and greater than 50% collapsible, you're either euvolemic or volume down. And if you have one but not the other, you're somewhere in between. The last important view is the apical 4-chamber view, which is sometimes the hardest to obtain in my experience. So as the name suggests, the probe goes at the apex of the heart, so at the 4th or 5th intercostal space with the probe marker facing the patient's left arm. And this gives you a horizontal cut of the heart, revealing, again, the 4 chambers, the left atrium, left ventricle, right atrium, right ventricle, as well as the respective valves. And this is one of the important views that are necessary for calculating ejection fraction. So that's it for bedside echo. Moving on to approach to hypoxia. So we'll start off with a case. So we have a 53-year-old man with hypertension, CAD, HFrEF with an EF of 35%, who was admitted 2 days ago for worsening lower extremity edema, shortness of breath, and weight gain over the past week, consistent with a CHF exacerbation. He was started on diuresis with IV Lasix, inpatient with good effect. So you are the intern covering on nights, and you suddenly get called that your patient is satting 84% on room air and not looking so great. So you rush over to bedside and you see that he's tachypnic and has increased work of breathing. What do you do next? So you'll see these sorts of cases quite often during residency. And my goal is not to review all the potential causes of hypoxia, but instead to provide everyone with a basic approach to hypoxia in the initial or acute setting. So what should you do? Before you proceed with any sort of diagnostic workup, your job in this moment is to assess the situation and determine if you need to call for any additional help. Therefore, you'll start with the ABC. So is the airway intact? Is the patient breathing? Is there a pulse? Now, assuming those things are fine, then you'll want to obtain a full set of vitals, and you also want to confirm the SAT on a monitor. And it's also important to ensure that there's a good pleth or waveform. So the left is an example of a good waveform, whereas the right is maybe not so good. So if there's a poor pleth, you can troubleshoot this by maybe switching the pulse ox to a different finger, maybe trying an earlobe or placing it on a forehead. Also, during this time, you want to make sure that the patient is placed on some form of supplemental O2. And we'll go over the different types of O2 delivery devices in a bit. Now, if you notice that your patient is rapidly worsening, it's starting to have worsening hypoxia, tachypnea, declining mental status, or you see evidence that they're starting to tire out, you may need to call a rapid response if it has not already been called at this point. And that brings a rapid response MD, a respiratory therapist, and an ICU trained nurse, although this may vary with your specific institution. And if you're anticipating a need for imminent intubation, you may need to call anesthesia and the medical ICU at this point. So I know this sounds overwhelming, but you'll most likely won't be making all these decisions by yourself. And you'll likely have a senior resident, a fellow, or another provider there to help you through this. So it's important to go through the spectrum of oxygen delivery devices, going from least to most intensive. So on the very left, we have nasal cannula, which goes up to 6 liters per minute. And just so you know, the oxygen flow on the wall or tank may be maxed out at 15, but really you're only delivering 6 liters through the nasal cannula. Next, we have Venturi masks, which honestly I'll skip because we don't use them that often in an emergent setting due to the fact that it uses set O2 concentrations, which you have to change out with different valves. Instead, what we use is the non-rebreather mask, which allows you to achieve higher O2 concentrations than normal masks. And it goes up to 15 liters per minute and up to approximately 90% FiO2. You can place the non-rebreather over the nasal cannula as well to give you that extra boost in O2. The next step is high flow nasal cannula, which goes up to 60 liters per minute and 100% FiO2. And it's a comfortable way to deliver warm, humidified oxygen in a very rapid manner. You may, however, decide to skip high flow and proceed directly to non-invasive positive pressure ventilation, which is namely CPAP or BiPAP, in situations where you anticipate the need to deliver PEEP or positive end expiratory pressure. And that can be useful in situations such as with pulmonary edema. You may also opt for non-invasive positive pressure if you're concerned, for example, that a patient with COPD is not only hypoxic, but is also hypercarbic and needs additional inspiratory pressure support over the PEEP, which is also known as BiPAP, in order to help the patient ventilate in addition to oxygenate. And lastly, the final and most invasive on the spectrum is intubation or mechanical ventilation. So your initial workup will vary with your differential diagnoses, but will most likely include a chest X-ray plus or minus an ABG at the minimum. You may also choose to include some basic labs like a CBC, chemistry. You may also choose to obtain an EKG. You can get a BNP if you're concerned for volume overload, troponin if you're concerned for some myocardial injury or ischemia. Imaging such as bedside echo or lung point of care ultrasound is really great. You can evaluate for any pleural effusions, pulmonary edema, or any gross cardiac abnormalities, and maybe even getting a CTA chest too if you're suspecting a pulmonary embolism. So other than your continued supportive care, your management of hypoxia will obviously be tailored to your differential diagnoses, but we unfortunately won't have time to go over all of that. So I hope I was able to provide everyone with a basic framework for approaching hypoxia in the initial setting. And remember, always have a very low threshold to call for additional help. And so this ties in nicely with our next topic, which is approach to DVT PE. So as you guys know, a DVT occurs when there's a thrombus in one or more of the deep veins in your body, usually occurs in the legs. And a typical presentation will be pain, swelling, erythema, and warmth of the affected extremity. And in your history, you'll want to ask for any long periods of immobility, any recent surgery, pregnancy, active malignancy, personal or family history of hypercoagulable conditions. And this will be important in determining whether a DVT or PE is provoked or triggered by risk factors, or unprovoked, meaning that there is no identified trigger. And this has important implications on duration of treatment, which we'll go over later. So for pulmonary embolism, a patient first develops a DVT, which then breaks off and travels through the right side of the heart and into the pulmonary arteries, causing an occlusion. So the typical presentation is sudden shortness of breath and sometimes chest pain. And on vital signs, you'll see acute hypoxia, tachycardia, and sometimes hypotension when it's severe enough. So you're probably all familiar with the Wells criteria for DVT and PE, which will help you with risk stratifying your patients. But the gold standard studies are the lower extremity ultrasound with Doppler for DVT and the CT angiogram of the chest for PE. For DVT, you may have heard of the Homan sign, which is calf pain on passive dorsiflexion of the foot, but don't use this test. It is unreliable. It has a low sensitivity and specificity. D-dimer is a highly sensitive test because it's elevated in nearly all patients with DVT, but it is also very non-specific because it can also be elevated in many other conditions. Therefore, it is more useful for ruling out DVT if negative in those with a low pretest probability. And in the end, your clinical judgment, physical exam, and history taking will be more useful than these tests. For PE, you have several adjunctive tests. So you can get an EKG and you'll most likely see sinus tachycardia. S1Q3T3 is a pathognomonic finding, but it is very uncommonly seen. D-dimer, again, is nonspecific, but may help you rule out a PE in those who have a low pretest probability to begin with. A lower extremity ultrasound to evaluate for any DVT may also be helpful diagnostically. A VQ scan may be utilized for those who have contraindications for a CTA, such as those who are pregnant, those who have severe allergy to contrast, or those who have renal failure, but it requires you to have normal lungs at baseline. And finally, bedside echo is also a great adjunctive tool to assess for acute right ventricular strain. So just very briefly about a right ventricular strain, on the left photo, we see the apical four-chamber view, and we can see an overall very dilated right ventricle that is actually much larger than the left ventricle. You could also potentially see McConnell sign in this view, and you won't see it right now because it's not a video, but McConnell sign is essentially right ventricular free wall akinesis with apical sparing. So in the parasternal short axis view in the right photo, you can see what is called the D sign. And this is where you get interventricular septal flattening, and the RV becomes so dilated that it begins to look like a D shape or like a backwards D shape. In terms of your management, you'll first want to determine whether your patient is stable or unstable. Now, if your patients are hemodynamically stable, then you can proceed with empiric anticoagulation. And the most common options you'll see include unfractionated heparin, low molecular weight heparin, such as enoxaparin, DOACs, such as apixaban or rivaroxaban, and vitamin K antagonist, most commonly warfarin. In the active inpatient setting, we may actually opt to start with IV unfractionated heparin infusion, as it is more easily titratable if further procedures or surgeries need to be performed. Otherwise, you'll most likely be prescribing DOACs for maintenance therapy. In fact, DOACs are actually recommended over warfarin due to lower risk of bleeding, although reversal agents are less commonly available. Now, in terms of treatment duration, you'll need to decide if the DVT or PE was provoked or unprovoked, based on clinical triggers I have previously mentioned, and whether those triggers are transient or chronic. So if provoked by a transient risk factor, we typically treat with 3 to 6 months of anticoagulation for primary treatment without secondary prevention. And if unprovoked or provoked by a chronic risk factor that you don't anticipate to resolve, then we treat for 3 to 6 months of primary treatment, followed by indefinite therapy for secondary prevention. And just some other considerations for those who have contraindications to anticoagulation or recurrent VTE on anticoagulation, then placement of an IVC filter may be warranted. And lastly, reperfusion therapy such as thrombolysis with catheter-directed TPA or embolectomy are generally reserved for hemodynamically unstable cases of DVT-PE. And we may also use this in rare cases of limb-threatening DVT, also known as phlegmasia ceruleum dolens, where a large DVT compromises arterial blood flow. So how to run a code, ACLS overview. So I just want you to imagine a situation. You're the primary code team and you're going about your day, you're writing your notes when you suddenly hear overhead, adult medical emergency or code blue. So you run over to the room and you find the patient is lying in bed unresponsive. The nurse has already confirmed a lack of pulse and has started chest compressions, and you're the first resident to arrive to the room. What do? So I know this is a very overwhelming situation, but it's important to stay calm and to remember your priorities. So these are your priority tasks that should ideally be performed in the first minute of your arrival. So the first thing you need to do is to take charge and introduce yourself as the code leader. So, hi, my name is Dr. Shen. I'll be running this code. It's important to take command and speak with confidence because it will actually help to calm everyone in the room despite all of the hecticness. And one thing to remember, especially if you're feeling very nervous or anxious in this situation, is that the patient has already died in this situation and you cannot make it any worse. The next thing you need to do is confirm code status, which seems kind of obvious, but it is sometimes overlooked. And assuming the patient is full code, situate yourself at the foot of the bed, as that's where the code leader should stand to effectively communicate with all members in the room. And you want to ensure that the backboard is in place underneath the patient as soon as possible in order to allow for effective chest compressions. And I just want to reiterate, uninterrupted effective chest compressions are the priority. You also want to ensure that the pads are on so you can do a rhythm check ASAP. And it's super important to know what the initial non-perfusing rhythm is that you're dealing with, because that will dictate your path down the ACLS algorithm. You'll also want to assign and identify roles. So who is your nurse pushing medications? Is there a line for chest compressions? Is there someone at the head of the bed managing the airway? Is there someone timing and documenting all the events in the encounter? And if you don't have people in these roles, it's time to just assign them. Also, very important, you need to ensure that you clear the room of any personnel who are not essential to the code. And also, you want to make sure that someone is working on intravenous access or intraosseous access if not already available. So quickly going over the ACLS algorithm. If you rhythm check and the patient is in VFib or pulsus VTAC, your priority is to deliver a defibrillation ASAP. It's not giving epi first, it's not starting amiodarone. You need to defibrillate as soon as possible. And once you've delivered the shock, you'll continue CPR with pulse and rhythm checks every 2 minutes, delivering further shocks if indicated. In the meantime, you'll start giving epinephrine 1 milligram every 3 to 5 minutes, and you can also start on amiodarone or lidocaine. And this essentially continues until you reach a conclusion to the code. Now, if your patient is in asystole or in pulsus electrical activity, the algorithm is very simple. Your priority is to initiate epinephrine ASAP. and you'll continue giving it every 3 to 5 minutes. You'll continue CPR with pulse and rhythm checks every 2 minutes, and it's as simple as that. This will go on until you either obtain ROSC or the code concludes. So after you've completed your priority tasks, you can start thinking about next steps, such as having someone look into the patient's history and presentation. So why are they in a hospital? As this may give you a clue as to why they coded. You may want someone to look at any notable recent labs, like any electrolyte abnormalities. And at this time, you should begin thinking about reversible causes, which are your H's and T's, which is illustrated in the table on the right. And this can potentially guide any additional tailored therapies. It's also important to have someone call family in this time to give an update about the situation. And if you haven't obtained ROSC by 20 minutes or so and you deem their prognosis to be very poor, at this time you should consider discontinuing resuscitative efforts. So other miscellaneous tips that I've learned from others and from my own mistakes. So firstly, don't ask, instead give commands. So instead of saying, can we give epi now, say, please push 1 milligram of epi now. So a slight difference, but it's very important. It's also important to use closed loop communication so nothing gets lost. And you also find that it's very helpful to summarize out loud what has been done thus far and to narrate your thought process. And also feel free to ask if anyone else has any other ideas. Remember, this is a collaborative effort. Another thing is don't ask for rainbow labs during a code. I've seen this done quite a few times, but they ultimately disrupt the flow of the code and they take away from the primary objective, which is doing chest compressions and following the ACLS algorithm. They're also unlikely to come back for you in time for you to react to them. And they most likely will also demonstrate multiple derangements in the setting of the patient being found down with inadequate perfusion for some unknown period of time. But that being said, one thing you can easily obtain is a finger stick for glucose, which can result quickly and allow you to react to it. And the last thing I'd recommend is to download an ACLS app to your phone. And my favorite is the MGH ACLS app, but there are many similar apps in the store. They will allow you to review the different ACLS algorithms and any medication dosages, and will allow you to time and document events during the code. Overall, super useful and highly recommended. So that's it for ACLS. Thanks so much for listening, and I'll pass it back over to Brandon for approach to hyponatremia. Thank you.
Okay, thanks. So I'm going to talk a little bit about hyponatremia. This is a topic that will often come up, and you'll usually see it, but how do you approach it? And I'm just going to talk about approach today and not too much about treatment, because I think it's more important to know what you're looking at first. So the principle here is that water always follows salt, okay? And that's going to be important when you look at urine studies, and I'll show you why in a moment. Hyponatremia is defined as a serum sodium less than 135, okay? And when you have a patient who has hyponatremia, I'm going to show you an algorithmic way that you can approach it. The first step is typically calculating or even measuring the serum osmolality. And there's a very sort of popular formula shown here, which is 2 times the sodium plus glucose over 18 plus the BUN over 2.8. This can help you get a calculated osmol of the serum. And the range that you'll typically get is for a normal patient is between 280 and 285, though this may vary based on institution, what resource you're using. Now, if you have someone who has what I would say is hyperosmolar hyponatremia, then in that case, you have an issue typically with lipids or proteins in the blood. This is actually not really a hyponatremia. This is that they have something else in there that's screwing up the lab's calculation. But oftentimes it can be helpful because it can tell you that there's something else wrong. And common things you want to watch out for that can cause this are things like obstructive jaundice or any reason for bilirubinemia, hyperproteinemia. So did they just get an IVIG infusion and you just drew some blood? Maybe they have multiple myeloma. So that's B cells throwing tons of antibodies everywhere in the blood. Or do they have high triglycerides and it's a familial problem? If you have someone who, or I'm sorry, that was isotonic hyponatremia. If you have someone who has hypertonic hyponatremia, this is because, as the name says, there's a lot of tonicity, or there's a lot of stuff in the blood. And the stuff that we're talking about are things that are osmotically active solutes. And these can include things like toxic alcohols, like ethylene glycol, propylene glycol, mannitol or sorbitol. For you people going into neuro ICU or interested in neurology, we often use that in those settings. Radio contrast dyes, and this will often be confirmed when you have someone who has hypertonic hyponatremia, where you measure the actual serum osm, compare it to your calculated, and if there's a gap, then you're on that track. Another common thing you can see is glucose problems, so HHS or DKA, and you have to make an adjustment. So glucose is active. For every 100 units of glucose, you need to adjust the sodium by increasing the measured value by 1.6, and seeing after your adjustments, do you actually still have hyponatremia, or is it corrected and all you have is just a ton of sugar in the blood? Lastly, kidney failure can be an issue. BUN is used in the calculated osmolality. If you have high uremia, you actually should ignore the BUN segment and see if your recalculation of the osms helps you put yourself into a normal or even a hypoosmotic state. And for the purposes, this is a reminder, for the purposes of this talk, for those of you that are more renal inclined, I'm using tonicity and osmoles as interchangeable. They're actually not. Tonicity ignores the BUN, but because this is a basic talk, I'm going to use them interchangeably. You can sue me later. So, okay, so you have your different causes here. These are the common things for hypertonic hyponatremia. What if you have a hypotonic case? So in hypotonic hyponatremia, you want to then ask yourself, what is the volume status? Never a bad question to ask in other cases, but particularly in this one as well. The way you determine that is through the history, careful physical exam, maybe even using a point of care ultrasound like Miles has been saying this whole time. Urine sodium and urine osm can be helpful too, and I'll tell you why in a moment. If you have someone who you believe is actually hypervolemic, so they have high amounts of volume or basically salt water in their body, you have to ask yourself if the gains of that extra volume is from the problems with the renal system, so kidney, it's not able to take off that extra fluid, or is it gaining it from somewhere else? Are you just gaining too much and the kidneys can't put it out enough? In the case of extra renal gains, the problems you want to think about are things like heart failure, things like cirrhosis, low albumin states, things like nephrotic syndrome, also another low albumin state. And you can see that the urine sodium in these cases often correlates to something of less than 20. In the cases of renal problems, where you have a failure to expel salt and water, in these cases, you have impaired excretion. When a kidney is injured, oftentimes it'll just drop a ton of stuff, and you might see that the urine sodium is high, but it's not high enough to the point where it's actually expelling the amount of water or salt that it should be. So this is an impaired excretion issue. And in these cases, usually you will be trying to diurese the patient, diuresing meaning giving furosemide, for example, or sodium and fluid restricting them, or even in the very, very severe cases, you'll do dialysis. Now, what if you have a hypovolemic hypotonic hyponatremia? Well, in this case, you have the exact same framework. Are you losing it from your kidneys, or are you losing it from somewhere else? In these cases, urine osm, which is a measure of ADH activity, usually will be very high because your body's trying to hold on to a ton of free water. It knows it's losing it. In the case that you're losing it from somewhere else, not the kidneys will function normally. So it will try to hold on to its salt. Urine salt measures how much the kidney let go of. It's not going to let go of anything. Remember, because water follows salt. So it's trying to hold on to everything. In those cases, you'll have patients who are vomiting, having diarrhea, dehydration, maybe they're not drinking enough, blood loss. I hope you're not necessarily using urine studies to figure out if you're bleeding, but it can help you. And insensible losses. Do you have a burn patient? In terms of renal losses, maybe the kidney is the problem. And in that case, they're dumping tons of salt. So the salt's going to be high in the urine sodium and the urine, and things like ATN, AKI, so kidney injury, when you're knocking out the kidney so much they're just losing a ton of things too, that can happen. Diuretics can be a problem, and some other conditions too, which are a little bit more exotic. In these cases, you want to give fluids back, but it's also going to require reversing the problem, right? So if you have someone who's using diuretics, you might want to stop them. The next thing is, what if you're euvolemic? This is very hard to tell, and a caveat to this is volume is always notoriously hard to tell. You need to use every single tool at your disposal, whether it's ultrasound, whether it's physical exam, to tell, because oftentimes someone will be super thin. Maybe they look dry, but actually they're intravascularly overloaded. That's something you'll pick up during your residency training. But let's say you've determined that you're bulimic. So what now? So it depends on what the syndrome is. So if you have a patient who's a marathon runner, they're drinking a ton, then maybe you're dealing with primary polydipsia and their urine studies will be weird. You'll have a high urine sodium and low urine osm. Maybe there's someone who doesn't eat a lot of solutes. Taking in a healthy amount of salt is how your kidney is able to concentrate urine. If you don't take in salt through your diet, you're going to lose it eventually. Or maybe it's something that's very weird. So you can have cases where you have high urine sodium and high urine osm. You're like, what the heck? Why am I dumping salt, but I'm also trying to keep free water? Well, that's kind of what you see in SIADH, but there's also other things that can cause it too. Hypothyroidism, Addison's disease, renal tubular acidosis. In these cases, they're all so different. The treatment is reversing the cause. Sometimes it includes fluid restrictions, sometimes it includes weird salt tabs, urea tabs, and sometimes it includes weirder things like Baptans. But the point of this is to illustrate that in euvolemia, you have very different things and you have to be careful of them. Now, this is another slide I'd like you to save, because this is, again, just a framework to help you chart your way through the problem when you have it. I don't expect you to remember all of these things. You're definitely not going to. You're going to forget 300 times before you get it down. So have this as a reference when you're an intern. Okay, so I'm going to stop that sharing. I'm going to move over to the next one, which is acid base. So you've probably been told that an acid base for the test, you don't have to worry about it. But unfortunately, in residency, you have to worry about this so darn much, it's annoying. Step one probably only has one question. I think in residency, I'm asked about this all the time. So tactics to finding your problems and their sources, okay? So the diagnostic approach is going to be a flow chart. It's gonna be something you'll save. And I'm just gonna talk about diagnosis and adjustments. I'm not gonna talk about treatment. That'll take way too long. So first, when you have a when you have an acidic alkalemic problem, you need to prove to yourself, do I have acidemia or alkalemia? And that's based on the pH. Okay, so if you have acidemia, you're going to have a pH of less than 7.4. If you're going to have alkalemia, you have greater than 7.4. This is in the idealistic sense, right? Let's start with acidemia. So the first question you want to ask yourself is, do you have a respiratory or do you have a metabolic problem? In the case of a respiratory problem, you're going to look at the CO2, specifically in an ABG, an arterial blood gas. If it's greater than 40, then you have a primary respiratory acidosis, okay? Now, the differential for this is anything that can cause you to not ventilate, and ventilating meaning blow off all that CO2 in your lungs. One reason can be opiates. You're dosed on opiates, you're driven down your respiratory drive and you can't ventilate. Asthma, COPD are chronic retainers. Obstructive sleep apnea is another reason. And muscular weakness, so like myasthenia gravis, ALS, those types of things. If you have CO2 content that's less than 40, then you probably have a metabolic acidosis. You have a respiratory compensation. You're blowing off excess CO2 because something else is wrong. So in the metabolic acidosis, you want to ask yourself if you have an anion gap, okay? If you have an anion gap, which is anything, did I even write the formula? I didn't, okay. Well, so with your anion gap formula, okay, if you have a gap, then you're going to look at your anion gap acidosis. I'm going to ask my other residents to write that formula in the chat. If you probably remember the mud piles mnemonic, and I'm going to illustrate that here, right? So you have different causes. You have methanol, you have uremia, decay, propylene glycol, these other exotic things. If you don't have these, then if you don't have an anion gap, then you'll have a non-anion gap acidosis. So in those cases, usually it's from a loss. I do this. I don't think everyone necessarily does this. Oftentimes you can get it from the history of a patient, but you can look at your urine lights and you can actually calculate whether or not you have a urine lights gap. It's a gap of greater than 10. And the cases where you don't have it, it's usually diarrheal losses that's causing your acidosis. If it is greater than 10, then you actually have some renal disease, okay? Again, oftentimes you can actually figure this out just from the history itself. Now, that's enough about acid. What if you have alkalemia? So that's a pH of 7.4, greater than 7.4. You again ask yourself if it's CO2 based. respiratory based. If your PCO2 is less than 40, you have a respiratory alkalosis, so reasons to blow off too much CO2. And in that case, you have things like pain. Maybe someone's in tons of pain and you just have not controlled it. Maybe they're anxious. Maybe they have hypoxemia or air hunger. That can be a reason. If you're breathing quickly because you're hypoxemic, you can then artificially lower, or you can then lower your CO2 content. In the case that the CO2 is greater than 40, then you have a metabolic alkalosis issue. And the key here is that it's an issue of aldosterone, okay? So in this case, you can then use your fancy urine lights and figure out where the source is. If urine chloride is less than 10, you have something that's due to volume. Aldosterone's active, you have been chronically metabolically alkalotic, so meaning greater than 2 days or more of time, and you need to give volume back. Oftentimes, these will be patients who are over-diuresed or dehydrated, or they're vomiting or on NG suctioning all the time. You see that often on surgery. In the case that it's a non-volume responsive problem, then you have to ask yourself, is this patient known to have bad hypertension or not? And that could be a key. If they're chronically hypertensive despite medications, then you can look for causes of hyperaldosteronism, which I won't dig into today. If they're no, then usually it's a congenital issue, okay? This is another slide. Just save it, use it for yourself as an intern. Okay. Now the last thing is adjustment. So I'm not going to go over these too much in detail, but if you have a metabolic acidosis, you have to ask yourself, is there other things on top of it? Patients can have all sorts of problems. You want to ask yourself if there's respiratory compensation. You apply Winter's formula. I'm sure all of you guys have done that. Sarcasm. And then if the given is greater, if the given amount of PCO2 you should have is more than you're expected based on the formula, you have a new respiratory acidosis on top. If it's less, you also have a respiratory alkalosis on top. And if it's equal, then your respiratory status is appropriate to the amount of primary metabolic acidosis. For anion gas, you calculate a delta-delta. There's a formula right there. We won't go into it. There's a lot of ways to interpret this. You can use Google or UpToDate to figure out what it means. But it helps you figure out if there's another overlying process as well. For respiratory issues, you have to ask yourself, is this a new respiratory issue or is it chronically there? And also, am I metabolically compensating properly? For first, if acute or chronic, every 10 points of CO2 going in either direction, you should expect a pH change. In acute, again, less than 48 hours, you should expect a pH change in the direction you anticipate of 0.08, added or subtracted from 7.4 pH. If it's chronic, then it's a smaller change. For in terms of metabolic compensation, for every 10 points of CO2, you'll have different types of metabolic shifts. You'll have changes in the bicarb in the plus direction. If it's respiratory alkalosis, you'll have changes in the bicarb in the negative direction. And this is to help you figure out if your correction that you calculate is not what you actually get, you may have a new process on top. So it's helpful to have this. And again, save this slide as well, because it'll help you figure out how to do things step by step. And that's all I have for metabolic acidosis and alkalosis stuff. Your voice is muted out by the music.
I just want to say, we'll take a 2-minute intermission, but in this time, I would really appreciate if you guys would take the time to fill out the link for feedback. Anything you say helps us improve for the next year. And a lot of our residents are part of clinician educated track. So anything you write could be potentially included in their portfolio. So if you can just take a couple minutes to do that, we really appreciate it. Thank you. All right, we're back. Akash is up.
Can you hear me?
Yep.
Great. All right, so I have the next couple topics. So we're gonna first talk about, let's say you're on nights, you get a call for medications about pain, nausea. So the next slide, we're gonna kind of go over just common things you'll get called about if you're a night intern. So imagine you're on the wards, called by the nurse, the patient's in pain. So one of my first rules about a patient in pain is it's good to go assess the patient and see what their pain is, because there's a difference between a patient saying to you, I'm in 10 out of 10 pain, but they look very comfortable. They're not grabbing any body part or anything like that, versus a patient in extreme agony. So it's good to lay eyes on the patient if they're in pain. The second thing is it's really important to look in the chart. Look if they have any history of any substance use, any opioid dependence, if there are things that have worked for them in the past, what their comorbidities are. So those are kind of good to keep in mind. And then also, if the day team had used any medications during the hospitalization or left any recommendations for you. But if none of those are available, I like to start really small. So I like to actually give Tylenol. And you can give actually up to 3 grams in a day in a 24-hour period of that. So sometimes I'll give a patient 1 gram, and then I'll put like a topical lidocaine patch. So that's like an anesthetic. So if you think about the dental office, like Oragel, you can give lidocaine, same kind of thing in a patch, or even like a topical diclofenac, which is an NSAID gel as well, to start sort of for a patient. Now, if a patient has no contraindications and you may want to try something like ibuprofen, that's kind of a next step I think about. And I usually use that for patients as long as there's no history of gastritis or any peptic ulcer disease, no issues with their kidneys, and no thrombocytopenia. Now, if a patient's in an extreme amount of pain, you know, and they're not, and the Tylenol's not helping, the NSAID's not helping, then I start to entertain the idea of opioids. And I make sure that a patient is not on methadone or Suboxone, which is buprenorphine naloxone, if I give this, because I have seen patients where opioids are given and sometimes providers didn't look, and you actually can precipitate withdrawal if you do give these medications. And there's sort of a spectrum of opioids I like to think about. So small opioids that I sometimes like are tramadol. So that's a weak opioid you can consider. Norco is a great one. It's a hydrocodone Tylenol combination. I love giving that out if that's available for a patient. And then you have things like oxycodone, morphine, and Dilaudid. And some of these medications may be available only IV or IM, depending upon which medication is. So oxycodone is oral, Norco is oral, tramadol is oral. Morphine can be given oral or IV, and that's important because you know, it's a little bit beyond the scope of this talk, but the IV or oral conversions of morphine, they're a little bit different depending upon what route it's given. And then Dilaudid can actually be PO or IV. So patients that have sort of a moderate amount of pain, I'll try tramadol, you know, as long as they're not on any serotonin agents, and I'm not worried about a serotonin syndrome because there are some serotonergic properties. I'll try oxycodone if you know, I think a patient really is in a lot of pain. But if they're 10 out of 10 and you know they have like really bad kidney disease where I can't use morphine and I'm kind of against the wall, then I will sometimes give in and give Dilaudid. And usually I'll do a very low dose, like 0.5. That way, I think with pain meds, it's usually good to start small so you can give additional doses. And then I let the day team know kind of what happened overnight so that they can maybe help me with a good plan for the next night I have the patient. Coupled with pain is sleep. So sometimes patients in pain, you can give them a weak pain medication and also give them something for sleep. So I kind of like to avoid benzos for sleep if I can, or medications like Ambien, which is Zolpidem. these medications can be very sedating, which is not good for our geriatric population. So I usually like to start with melatonin. And just so you know, melatonin is usually good to give a couple hours before sleep. 6 milligrams is a good dose to try. And then trazodone has an off-label use for insomnia. You can start at doses of 25, 50 is good, and you can go as high as 75, 100. I usually feel a little uncomfortable doing that. So sometimes I'll give a dose of 50, and if that's not working, I'll try an extra dose of 25 for sleep. One of the most common things that you'll get called about by a nurse for a patient is if a patient is agitated. So what you want to do is you want to understand, what do they mean by agitated? Are they just cranky and fussy and just grumpy and need to be reoriented? Is it somebody who's like thrashing around, throwing things, threatening staff? Because those are two different things. So typically I like to start with just going to see the patient, seeing if the staff can reorient the patient, if we can just maybe give them some medication for sleep, like trazodone or melatonin, and stopping at that. Now, if the patient's very aggressive and threatening, then you have to consider some antipsychotics. So you're thinking about, can the patient take something like Haldol or Seroquel? And that will depend on, can they take something by mouth, which is Seroquel, or do you need like IV or IM, which would be like Haldol or olanzapine. In any case of antipsychotic, make sure you have a EKG on the chart, because these can be QTC prolonging. If you're in a case where you can't use things that are QTC prolonging because they have some cardiac issues, then in that case, I would reach for like a benzo, like an Ativan, and you can give like a 0.5, 1, 2, depending upon how the patient is. So that's kind of about agitation. And then constipation is another big call you guys will get about at night. So make sure the patient's having gas, they're not in belly pain, you're not concerned for any type of like obstruction. And then, Isa kind of alluded to these on her previous presentation about cirrhosis, but Miralax is good. You can mix it. Lactulose, I think it tastes icky personally, having tried it. Some people like it. I tend to like Miralax. Milk of magnesia is really good. And then depending upon how adventurous you are, you can actually just give mag citrate. It tends to work really well. If Miralax and some of these other ones aren't working, they just drink about 200 mLs. And usually it takes about 30 to 60 minutes to get an effect. Now, if oral agents aren't working, you can consider like a suppository if the patient and nurse feel comfortable. And then if a suppository isn't working, considering like an enema, again, where they go up the other end. And usually I like to ask the nurse what they want. Do they want tap water, soap suds? And if they leave it up to me, I just go for a tap water enema. Or lactulose enemas are there as well. The last issue I wanted to mention is just nausea. So that's a really common cause. They'll tell you patient's nauseous, they threw up. Obviously, like any of these things, it's good to assess the patient. But make sure you're not missing any causes of nausea, like do they have a bowel obstruction? Do they have some infection going on? Things like that. But to treat the symptoms of nausea, a couple medications I like to think about are Zofran, which is ondansetron. So that's usually my first line. You can give it oral or IV. And Reglan is another one as well. I can never say this medication, metoclopramide, if I'm saying that correctly, and then Compazine. The one caveats with all these is that, especially with Reglan and Compazine, these can also affect the QTC. So make sure there's an EKG on the chart as well, or get one. That way you're not affecting that. And again, if QTC is an issue, you can actually give Ativan as well for nausea. Again, I tend not to do that because of the sedating effects, etc. But if you absolutely have to, that's one. Or even a common thing that I've seen some of the residents do is get an alcohol wipe, have a patient sniff it if they're willing to do it, take a big whiff, and that actually will calm down a lot of nausea as well. So these are common things to just think about on the fly. And you can do like a GI cocktail, which usually will have some sort of like non-bloating agent, like simethicone with it, Maalox, things like that as well. So that's kind of my quick and dirty for cross-coverage issues. So I'm going to kind of shift to a different topic that's kind of not related, but something you guys will see a lot about is anemia. So whenever you look at a patient's chart, you're going to look at the hemoglobin and you're going to see if it's low. And then the next thing you guys may have learned in medical school is looking at the MCV. So that's the mean corpuscular volume. And I like to separate out these buckets into low MCV, normal MCV, high MCV. And we can type out the ranges in the chat so you can normally think about what that is. But just a quick and dirty, 90, lower than that is low, 90 to like 100-ish, and 100-ish is high. And then just things I like to think about for low MCV, your most common cause is going to be iron deficiency. That is very, very big. And then anemia of chronic disease as well. There are some examples of like thalassemias, hemoglobin E. These are very rare, but I just put them for thoroughness. Normal MCV, so other things to think about. Again, iron deficiency can cause this very, very early. Anemia of chronic disease. You want to make sure the patient isn't bleeding anywhere, so acute blood loss can fit that bucket. And then liver disease can also cause a normal to a high MCV in terms of anemia, sickle cell as well. So these are a couple causes, and then renal disease. If patients have ESRD and they're on some sort of agent as well. And then high MCV, the most common cause you'll see is folate, B12, liver disease, alcohol as well can cause it, which I neglected off this slide, but I'm adding that too. And then if patients are on chemotherapy, a lot of those medications can impact the folate metabolism and things like that. So that can cause high MCV. So again, just remember low, normal, high. This is your first starting point. And then the second starting point I like to think about is this anemia, is the patient's body responding appropriately or not appropriately to being anemic? So are they actually making those immature forms you learn about in med school, reticulocytes? So there's something called a reticulocyte count index. So if it's less than 2%, then I'm worried about, is there some sort of hypoproliferation component? So is the bone marrow suppressed? Is there some reason they can't produce it very well? Or is there some issue with getting the components? So maturation abnormalities, B12, folate, a B6 with sideroblastic anemia, and then iron can also kind of fit under this. So very common causes of hyperproliferative anemia. Again, iron deficiency, very common. Anemia of chronic disease, renal issues. There's a lot of medications that can cause hyperproliferation, like Zosyn, which Brandon talked about. That can actually be very, very notorious for that. And then some patients, if they have multiple lines down, you want to think about marrow failure as well. And then maturation abnormalities, B12, folate, a lot of these are nutritional. And then if patients are reticking normally, so above 2%, then you want to think about, are they bleeding somewhere? So that could be a cause, or are they hemolyzing? And there's multiple causes of hemolytic anemias, which I won't go through in depth, but you want to think about, is it an immune process? Is there some sort of underlying hemoglobinopathy like sickle cell? Is there something metabolic as well, membrane, and then mechanical, such as like if a patient has a mechanical aortic valve, for example. So I kind of wanted to come back to this slide and put these two together. So reticulocyte count, what you expect it to be low, what you expect it to be high. So the asterisks, like for chronic disease, iron deficiency, this can be low. For example, acute blood loss, like we talked about, we expect it to be kind of high. Sickle cell can be high as well. And then, cases of myelodysplasia, it's low. Chemotherapy, aplastic anemia, and then if they're hemolyzing, it's also going to be high. And then the RDW, I don't really use this. Some people do, but I think about it high RDW. If I see this in a normal or low MCV, I really think about iron deficiency. I just wanted to put this because you may see some people use this as well. That's that red cell distribution width you guys may have learned about in med school, where there's like just different variation in the sizes of RBCs. So that was my talk on anemia. I'm going to shift now to altered mental status. So altered mental status is very, very common. You're going to see this in the hospital. So there's different buckets to kind of think about in terms of why is a patient altered. The first thing you want to do is go assess. What do they mean by a patient being altered, right? Like what's their normal baseline like? Are they low energy? that's different, being confused versus somebody who's completely unresponsive. So you want to get a sense of how altered they are. When is it happening? Is it happening at night? Is it happening at day? Sometimes, patients that don't, particularly older population, they're going to be up all night. They're going to, sleep during the day. Their sleep-wake cycle's messed up, and they're going to be very, very agitated. So you just want to get a sense of that. One of the most common causes is this sort of toxic metabolic bucket. So if you ever consult neuro, that's going to be something they say a lot. And you want to rule out things like medications. Did they ingest something? Do they use drugs, alcohol? So this is kind of in that bucket. Infection is really common as well. So patients that have a UTI can, be very altered. Patients that are septic and bacteremic, like Brandon sort of talked about with antibiotics. Are you worried about an infection? So you have a very low threshold. So you oftentimes will do a pretty broad infectious workup for these patients. So getting a UA, getting a chest x-ray, thinking about blood cultures if there's other signs of infection as well. And then if they have like a stiff neck and you're concerned about like meningitis with a fever and other signs as well, or is there some occult abscess in an abdomen? So I had a patient with an uptrending white count one time. They were super altered. I didn't know why. I scanned them. He had 12 abscesses everywhere from a perfed bladder a week ago. Nobody knew. And that was really shocking because we had no idea. So low threshold for infectious workup in these patients. Metabolic as well. So Brandon just did a beautiful lecture on hyponatremia. Hyponatremia can cause patients to be altered. Get a blood sugar, get an AccuCheck. Are they hypoglycemic? Are you worried about, patients not breathing, blowing off CO2? Thyroid, never forget about the thyroid in any medical cause as well. So checking a TSH on these patients if it hasn't been done recently as well. And then other electrolytes like mag, K, I've seen those. And then neurologic as well. So these patients should get a neuro exam. If there's any concern of a focal deficit, think about a stroke. Sometimes patients may be altered for days and you have no clue why. You get an EEG and you find out they've been in like non-convulsive status. I've seen that happen as well. So again, very low threshold as well from thinking about neuro standpoints. And then other things like vasculitis, encephalitis, these tend to be rare, but things to think about. And then very, very common things, which I put in this other, I sort of talked about insomnia, constipation, believe it or not, can cause patients to be altered. I would say the top three things I see in our veterans are they constipated? Are they retaining urine? Or are they just delirious from being in the hospital, which can happen. That's hospital delirium. So these are things you want to think about, as well. And then pain can cause patients to be altered as well. So these are sort of the buckets I like to think about. I start with what does it mean to be altered? Are they having bowel movements? Are they retaining urine? Are they sleeping, waking? Okay, then I sort of go down my infectious. I look at the electrolytes, everything here. I look for the thyroid, and then I do a good neuro exam. And if there's any deficits, then I kind of go down this bucket here. And then always looking at the med list. What did they get through admission? Why are they altered if they've been in the hospital for a while? So kind of my next two talks are going to just be about code status and how to call a consult. These are going to be two things that you do very, very commonly as an intern. So we all kind of have a different method for talking about code status. So I just kind of wanted to put up here what sort of the different meanings are. And again, this will vary state to state. So kind of if I have a patient that's young or old, and a code status is something you're going to ask for every patient. One of the first things I ask a patient is I'll ask them, I'll ask them, if you were to get very sick, are you okay to go to the ICU? Because some people, they'll know what an ICU is. If they say yes, then I'll be like, so if you go to the ICU, if your blood pressure was to get low, would you be okay to get medications to support your blood pressure through a large IV in your neck? That's one thing. If your breathing were to get difficult, would you be okay to get a machine like a CPAP, a BiPAP? It feels like, sticking your head outside the car, driving on the highway with air coming that way. And if they say yes, that tells me they're okay for something called escalation of care. So that's the first piece. Are they okay to go to the ICU if they're very sick? So that's for the first piece. So that's kind of what comprehensive care I take to mean. Now, there's something called do not resuscitate or a full code. And so the way I'll explain that to a patient, and again, feel free to chime in the chat if other people have a different way of saying this, and I'll ask a patient is, if your heart were to stop, would you want us to do CPR to resuscitate you and try to bring you back? And I'll pause there for a second and see what a patient says. And if they ask me to explain that further, then I actually will explain, CPR means we push on your chest, we break ribs, we go through an algorithm, we give medications to kind of try to get your heart back and so forth. And so if a patient wants all that, that's what they mean by a full code. So they want to get all that. And I ask them as well along the same lines is, do they want a breathing tube if their breathing were to get really bad and compromised? And they'll say yes to that as well. So that will be all full code. Now, sometimes I'll have patients tell me they do not want resuscitation. So they don't want CPR, they don't want the chest compressions, the medications, but they are okay for a breathing tube. So that is something called DNR, DNI. So you'll sometimes see this in the chart. There are do not resuscitate, do not intubate, but they would be okay for this comprehensive care, okay to be in the ICU, okay for escalation. Sometimes I'll see patients that are DNR, comprehensive care, and this can get iffy. Sometimes the patients will be like, if they code once, they're okay, but if they were code again, not to. So I've sometimes seen this, and this is very state dependent. We don't do that in Connecticut, but Ohio, where I did my intern year, we had this. And then sometimes you'll want to ask patients to, if their heart rhythm.
I think Akash's connection might have cut out.
For the sake of time, does one of you want to complete talking about code status?
Talk about like letting things take their course, pain, and so forth. And then I'm keeping.
Hey, Akash, you cut off for about maybe 20 seconds. Oh.
I think he was talking about comfort measures. So the difference is full code is we'll do everything when you die in an attempt to restart your heart and bring you back to life. Do not resuscitate is we will not do anything. So we will not do chest compressions. DNI is do not intubate. So we will not put a breathing tube down your throat. There are certain states, depending on your institution, where you can be all or nothing. Some institutions will, or some states do not allow for you to not be able to be resuscitated without ventilation, because when your heart stops beating, your lungs stop breathing. And so this will require a tube. And then comfort measures only is the patient who is still alive, but has exhausted all courses of treatment and has elected to prioritize being comfortable or not feeling pain over staying alive. And so we don't actively give them anything to hasten death, but we do support them with pain medications, and we start to peel back the medicines that they don't need for comfort, and also giving oxygen and things like that that are supportive. Right, I'm not sure how many topics are left, but this might be a good time to transition to the Q&A.
Yeah, let's just transition to Q&A. The only topic left is how to call a consult, and that could also roll in as part of the Q&A.
Okay, we can include that in the Q&A as well.
Can you hear me now?
Hey, Clash. Yeah, I just summarized the end of all the definitions that you gave.
Okay,
perfect. If you want to go to how to, call a consult.
Yeah. And then after that,
and then we'll go to our Q&A.
Perfect. Sorry about that. Let me share my screen here. Perfect. Okay. 1 second. Okay. Everyone can hear me, right? Perfect. Okay. Thanks guys for doing that. So last thing I want to go over is how to call a consult. So these are the 5 C's of calling a consult. So you're a new intern. The first thing you want to do whenever you call a consult is the first C. You want to state your name and what service you're from. And then you want to actually confirm that you're talking to the right specialist. So believe it or not, I've sometimes called people for consult, and the number listed on MIN is like not the right service. So you want to be like, hi, this is Dr. Goop, Akash. I always like to say first name, by the way, not saying doctor, because you're calling a colleague. Like, this is Akash. I'm the intern on the medical service. Am I speaking to Ray from cardiology? And Ray will be like, correct. And then the next thing you want to say is, I have a new consult for you. Are you near a computer? So you want to give them the patient's name, MR, and then where they are, and then the reason for consult. I usually like to say that very upfront. So this is sort of the communication part of that. So reason for consult for Ray would be chest pain. For example, in the setting of elevated troponin, I'm concerned about an MI. And so, so you have a question, and you've confirmed it's your consultant, and then you want to tell your consultant just a very brief summary of the patient and then what you've done that's pertinent for that specialty. So I would tell Ray, I have this guy, he's 89, he's diabetic, he has hyperlipidemia, he has no other concern of cardiac history. He came in for chest pain for the last couple of days. He said it was really bad with rest, really bad with activity. We got an EKG and a troponin when he came in. His troponin was high and it continues to go up. I'm concerned on his EKG of some ST changes in the anterior leads. So I was wondering if you could take a look and give me your thoughts on whether or not he may need some intervention. And so that's kind of, what you want to do, right? You want to give them a little summary of what happened, what workup you've done, and then, ask your consultant, how they can maybe help you, maybe leading them on a little bit. And that's a little bit more of an advanced skill, the leading on. Sometimes, like rheumatology, for example, which is what I want to go into, you'll tell them, like, I have this patient, he's fevering, he has joint pains, we've checked labs, they're all negative. We don't really know what's going on. We're just wondering if there's something rheumatologic that you could explain. Or if I call Brandon, same thing, like, I've done all this workup, I summarize the hospital course, like, I have this guy, he's got belly pain, he's fevering, his liver enzymes are really high, he's saying he had recent travel a couple weeks ago. I'm concerned if there's an infectious process. Do you mind just taking a look? That kind of thing too. So I think being really polite is important. And some consultants, you may find are a little tougher, like surgery and things, sometimes they're a little, maybe a little tough to talk to, but that's okay. I think, like, just doing the best you can, making sure you communicate is important. And then after you've called the consultant, they're very busy, so give them some time. But if you haven't heard from them, closing the loop's really important. You can text them or call them if, depending upon how emergent it is, just be like, hey, like, any updates on our guy, like anything like I should get now or whatever. And then always thank the consultant for their time, because they're always very busy, and it's a lot of work for a consultant to see a patient and kind of weigh in. So those are kind of the things I have about a consult. And then here's an example I just pasted in, which I won't read through, but you guys can look at, about a patient the ED's calling, like, for asthma. And that's all I got.
All right. Well, thank you so much. Those were amazing talks by all 4 speakers. We're going to open the floor now to all our medical students to ask questions. And these don't have to be topic-specific questions. They can be logistic questions, questions about transitioning to intern year, how to be a good sub-I, applications. Our speakers are very happy to take the next 20 minutes to talk about whatever you want. And please note that from now on, the recording is going to be turned off, because we want to be able to be as candid with you as possible. Please, once again, please do fill in that feedback survey. It would really help us for the next year. Our first question is from